For as introduction, my name is Terrance Chikurunhe. I'm one of the senior commissioning managers for NHS England Midlands region. There are three of us, and each of us have got responsibility for two ICBs for the commissioning of dentistry, optometry, and pharmacy. So for the purposes of today, I'll be talking about giving you a bit of an update of what's happening in dentistry. And next slide, please. So just as a bit of background and some key points, there is always a confusion around, do you register with a dentist or do you not register with a dentist? And a lot of patients or the population do view their relationship with the dentist as the same as the GP, but actually that's not the case because dental dentists don't hold a registration. So it's a message that is confusing, and we've asked our national team to work with the Department of Health to try and put this message out and clarify it, because it's got not only implications in Worcestershire as a county, but it's got a national-wide implication, because there's an awful lot of confusion. And I think as we discuss further, some of that will come across, because patients will say, oh, they've been seeing a dentist for a period and they're told you are not registered with us anymore. So there is a confusion in the public persona, but actually the formal position is that you don't register with a dental practice. The second thing I wanted to mention is that dentistry, like most healthcare services, was severely impacted by COVID pandemic in many ways. And this is not only in the reduction of access, which is the main thing that has happened over the past 2 years from March 2020, when we stopped services because of the pandemic. It has had a severe impact in many ways, in the sense that workforce have been impacted. The working behavior of our dentists has also changed over that period. We also have an accumulation of backlogs of people who perhaps would have had their checkups in between and have any intervention done, have not been able to do that. So we've got quite a lot of work to do. And the other thing that's happening in dentistry as well is we are struggling to get new dentists to come and join NHS dentistry, particularly in rural counties, of which Worcestershire is not protected in that. Having said that, there's some good news in that there's a steady recovery of services, and we are seeing from the activity that we monitor and manage from on a monthly basis that actually more patients are being seen within dental practices. And from April this year, there is a national mandate that all our dental practice should be operating at 100%. In the pandemic period, there was a payment protection in recognizing that in our dental practices, we still need to pay for electric bills, water bills, need to pay their staff and such like. So they maintained some level of funding, but there was an emphasis of prioritizing urgent care, vulnerable patients, and this meant reduced access. I know that there were members of the public who contacted the team in frustration that they couldn't have their checkups or scale and polish, which they were supposed to have. Unfortunately, it was a national consideration that during the pandemic, we really need to prioritize our vulnerable population. In Worcestershire, as I've mentioned before, and this is not restricted in Worcestershire, but even our neighboring county, Herefordshire, as part of the ICB, there are huge or significant challenges around the workforce, not only for clinical qualified dentists, but also for nurses. The march for information, I know perhaps it's not of interest for some of the people on the call, but Herefordshire is much more affected than Worcester in terms of the workforce issue, because some of our towns are much more urban, so they attract people to come and work in our dental practices. We are doing a number of initiatives, particularly to support urgent care, so that if a patient can't find a regular dentist, they can at the very least manage to get their toothache sorted out by going through NHS 111. So we have got sufficient capacity for patients. Any patient who is having pain, tooth pain, can be treated within the system, NHS system. We are starting also, not starting, but we're working much more closely with our local authority to strengthen oral health promotion, because we think where we have got restrictions in capacity or access is such an issue, we also need to strengthen the prevention agenda. So we are working with our local authority to make sure that we improve oral health promotion, and that's on an ICS footing. So that includes Worcestershire as well as Herefordshire. Next slide, please. So the next slide we are looking at the moment shows us sort of how dental activity has been performing over the last 24 months. What I've done there, because our reporting system now looks at an ICB position. So when I talk about ICB, that includes Worcestershire and Herefordshire as a county. So Worcestershire is the blue line you see on top. The orange colored one, that's the Midlands average. And also the green one is the Herefordshire one. As I've said, I think the Herefordshire county is much more challenged than Worcester, although, you know, when we talk about these things, it's all in relative forms, because actually some residents in Worcester don't see the difference between what's happening here and what's happening in Herefordshire. So in just to make this trend graph much more understandable, in normal times, the NHS dental activity performance usually is around 55 to 58%. And that's because some of the population does use private dentistry, and we don't have statistics for that. And there is a group of part of our population who don't access dental activity for one reason or the other, including choice, those who choose not to have a regular dentist, and they only go to a dentist when they need some intervention. So that's why the case is. So if our data, usually we look at 24-month access, because that's how we measure access for adults. And for children, it's a 12-month access. So if you look at the picture we're looking at the moment, there is a significant dip in from August, October 2021, which is last year. And then from April this year is starting to pick up, which is in line with what has been happening because of the pandemic. So services are starting to recover and the graph is starting to go up. What I would say is gonna take us quite a bit of time to reach back pre-pandemic levels, which is 2019 to 20, because for the reasons I've mentioned already, that we've got changes in workforce, we've got reduced access, we've got quite a lot of backlog to catch up with. So it's gonna take a bit of time and hard work to get to normal. Next slide, please. What I've included in the presentation is just to show some figures. This particular table shows us about 0 to 17-year-olds. As I've said, when we measure access for children, we look at a 12-month period for children. But as I've said, for adults, it's 24 months. For children, Worcestershire as a county is doing relatively better than the national average. As you can see, we're hitting 48% rather than 46.9 for which is the national one. Next slide, please. For adults, this is, we are at 36.6%. This is data up to June 2022, because that's how it's collected at the moment from national, from the national data source that we collect it from. We haven't got the next period, which goes up to December. But we are at 36%, and the nationally is about 37.4%. So I think what that says as well is that the challenges that we're facing in Worcestershire are not necessarily confined to the county, but there's a national issue around dental access across board. Next slide, please. One of the things that I've also wanted to include, just to give a pictorial representation of what's happening in dental access. What you're looking at, I know this is a map which shows different ICBs or ICSs as they're forming. And as you know, Worcester and Herefordshire are one ICB or ICS area. And if you look at Worcester, it's slightly lighter in color. So just for significance, if the lighter the color, the better the dental access, the darker the color, the worse access is. So if you look in Worcester, although we have got pockets, if you look, I think on the far left corner of Worcester where Evesham is, it's slightly darker. And also on the central Worcester is slightly darker, which means these are the pockets where we perhaps need to concentrate on in terms of dental access. And if you look at our neighbors, which is Herefordshire County, it's pretty dark there. And one of the reasons, because I also look after Herefordshire, is because we've got significant practices who have given up NHS services. And therefore that has diminished dental access. So they're in a far worse position than we have in Worcestershire. But as I've said, if you ask those who live in this county, they are still facing the same challenges but in relative terms, we are faring better than our neighbors in Herefordshire County. Next slide, please. Now, this picture we're looking at the moment, this map shows us the changes that have happened pre-pandemic and post-pandemic. So if you look at Worcester, there are some parts of the county where actually dental access is fared really well because of the colors which are much lighter. As I've said, if we compare it in relative terms with the Herefordshire, it's much darker, which means the situation is actually deteriorated. There are, as I've said, in Hereford, in Evesham, if you look at Evesham and central Worcester town, there are areas surrounding there which are far darker, and you can go up to Tenbury as well, which is there's a spot of darkness there, which means that access is actually diminished. And to be quite honest, particularly for Evesham, which is far darker, we have had two practices. One has reduced significantly its access, its NHS commitment, and the other dental practice have completely terminated. So, and just for comparison, so if you look at our neighbors in the southwest, Gloucestershire, they are pretty challenged in terms of dental access. Warwickshire, just out of interest, is doing fairly well, although when we spoke to some of the residents, they are struggling, particularly in areas like Bidford. Next slide, please. So internally, what we are doing to try and address some of these challenges is to have a much more strategic approach in addressing dental access. And this map here also feeds into what we're doing, including the other two we've just seen. This one looks at deprivation across the county. And what is interesting sometimes when you map deprivation and dental access, there is the areas that are much darker where there is perhaps more deprivation. There is also a challenge around dental access. So the two are quite interlinked. So from a strategic point of view, we are looking at that and see what else can we do to address the situation, because it's linked in the bigger agenda around the health inequalities. Next slide, please. Just to conclude, from an ICS perspective, so what are we doing for Herefordshire and also Worcestershire? Because we have started, as you know, at the moment, NHS England is the sole commissioner of dental services across Worcestershire County. So from April 2023, the services will be moving into an ICB. So the ICB will have full responsibility of commissioning dentistry across Worcestershire. So what we are starting to do now is to talk to our colleagues who work in ICS or ICB, if you want to call it from a formal perspective, to say what are the dental challenges, what we are doing, the initiatives we're doing at the moment, and what's the scale of the challenge. Yesterday we ran an interview panel, and we've recruited to a local dental network chair, having failed in the previous 2 attempts. So that's really a welcomed development. The local dental network chair is really responsible in driving quality across and working with various entities to raise the agenda around dental access as well. We have also looked at, because if you look at some of our dental practices, they've talked about that the payments are low. Nationally, we're given a guidance that you should be paying £23 per unit of dental activity, which is given an acronym name of UDA. So we have managed to transition everyone who is lower than 23 to that value, so that they are not disadvantaged in terms of recruiting workforce or sustaining their businesses. For Worcestershire in particular, we know that although our data set suggests that things may be better, but we still know that the base we are starting from is quite poor. Before the pandemic, we were not doing really well. We're doing well enough. You could go on a waiting list and then you'd be accepted by the dental practice. But that situation is really worsened. Although we know that there are pockets which are looking much better, but we know that the experiences that patients have are quite dire. So we're trying to improve that position. There's greater concern, particularly for some of our rural parts, as I've mentioned. If you look at the maps, Evesham is one that we're particularly focusing on, because we get a lot of queries around that. Tenbury is one of those that we're looking at as well. We are working through proposals for interim and long-term solutions. So just to give you an idea what we mean about that is we offer out activity to your existing dental practices to say, can you do more? And if they can, we obviously do a sense check and say, would they be able to do it? And if they can, we pass them additional activity. For long-term basis where we have lost activity, for example, in Evesham, where there's been a termination, we will be going through a full procurement process where we tender out that dental activity. Last point to make is that we are really keen to work with the Health Watch team in shaping some of our solutions, because we are conscious that you can't do things for the population, for the patients, without the patients on the table. So we're quite keen, genuinely, to understand what are the needs and how can we do things differently within the framework and the funding that we've got at the moment. I'll stop talking at that and take questions. Thank you.
Thank you very much, Terry. That was really interesting. Can I just ask a quick question about the capacity? So anybody who has tooth pain should be able to ring NHS 111 and find a local appointment. Is that done through the community teams, or have you got dental practices supporting that?
So when I talked about initiatives we're doing, we have commissioned additional activity for dental practices across the county. There are not many, but they are, I don't have the list in front of me, but we've got a combination of going through the community dental services, which is the main provider of urgent care, but we also have individual dental practices that provide urgent appointments for any patient who goes through NHS 11. There's a strict criteria that any patient who is in need of urgent care, they have to go through NHS 11, and they'll be told which dental practice they can approach.
Okay, thank you. So can we have any questions? We're going to unshare the presentation, Louise.
Sorry, Joe, I think there is a bit, I left one additional presentation, which is about dental reform.
Oh, brilliant. Okay. Off you go, Terry.
The next slide, please, sorry. So
Yeah.
dental reform, yes. So one of the things that is happening nationally, we recognize the dental provision is based on a national contract, and there is considerable recognition that actually it's not working well. The contract that we're working to was established in 2006. So if you can think about that, any business that runs, usually you change things every year. 2006, you could argue that's an absolute, it's obsolete now. We need to change things. So there are certain initiatives that are starting to happen as part of the dental reform. In summary, there is clear consideration that we do need to improve care for high needs patients. So if you are a patient who doesn't have doesn't have a regular dentist, you would struggle to find a dental practice that say will take you on, because they are worried that you have plenty of needs and the payment mechanism doesn't support that. That's why you find some of the dental practices are taking on a private basis, because they can unitize their payment and fee. So nationally, that's been a recognition. So we're trying to do that. So there's been a flexibility in payment. For example, to give you an example, if you've got 2 tooth extractions, for example, or 3 extractions or 3 fillings that you want to have on NHS, the NHS dentists have got flexibility to charge more and get additional payment around that. Previously, if you've got 3 fillings, they'll be done as recognized as one. So that has been disincentivizing NHS dentists to take on patients with high needs. There is also one of the key things that is coming down, although we are waiting for a regulation to come through, is for dentists to be much more accurate about what they are doing, dental practices, because we get a lot of practices that, patients who say, I've gone on a website, they've registered that they're taking on new patients. When I phone them, they're not taking any new patients. Or it could be the extreme end where no one else is taking any patients, while in actually they are. So there's going to be there's a regulation change which is going through that's not been formalized, but it will require dental practices to accurately register whether they're taking new patients or not. And that is the case with GPs. The other main thing that we're excited about is the skill mix, which is the introduction of, if you go into a GP, historically, we used to only I want to see my GP, but now you've got advanced nurse practitioners, you can have a paramedic, you can have all sorts of people who are fully qualified to see you depending on your needs. So that same concept is now being explored for dentistry, because you can have a therapist to see you and do your scale and polish, for example, rather than attend. So those are the exciting things that are starting to happen in dental. But as you know, any reform that you introduced, particularly in a national service, it will take time to embed. So these things will take time, but that doesn't limit us from a local level to do things differently. And we're asking them to do more as well. So usually we ask them to go as much as 102%, but that bar has now been lifted to 110%. Okay, thank you.
Brilliant, thank you very much. Can I just ask about the personalization of recall intervals? Are you going to be doing some comms around that? Because people are quite wedded to this idea that they go back every 6 months, aren't they?
Yes, we have been pushing for this to say it's a national, rather than having, just sending a communication and going on radio in Worcestershire for the population. We need this to be a national message. And there's been a commitment given nationally. So I'm not sure how that is developing to say, actually, as a patient, you don't necessarily need to be seen every 6 months by your dentist. because actually it does clog up the system. If you are dentally fit, which is the term we use in dentistry, you don't necessarily need to see a dentist every 6 months. They can say 18 months or over a year period. So don't panic when they say that. It means you're doing the right thing, or you've got good oral health.
Thanks very much. I've got a couple of questions for you, Terry, if that's okay. Simon.
Thank you, Terry, and thank you for your presentation. I just wanted to pick up on the recall intervals, if I could. And that's, I'm the cancer lead for Health Watch and Health Watch in the West Midlands as well. And prior to COVID, there was an awful lot made of one of the reasons for a regular dental health check was not about actually your teeth, but about a check for oral or other mandibular cancers. And I just want to check out with you whether or not this decision to change the interval is around a sort of clinical decision. And if that is that clinical decision linked to teeth and or cancers, or is it a pragmatic decision because of the capacity to deliver a service?
Yeah, so I may have limitations in how I can respond, Simon. It's unfortunate that Anna Hunt, who is my consultant in dental public health, is not on the call today because she would have had the clinical expertise to come from a clinical perspective. But certainly the changes that are being implemented are not for convenience sake or to create much more capacity by tweaking things, but they are informed by nice guidance in terms of this is the right thing to do. There is, of course, people who are high-risk patients who, even if we tweak, they still need to be maintained. Not necessarily 6 months is just a standard. It's just a bar, but there are patients who need to be seen every 3 months or even lesser than that because of the risk profile they present. So it's a clinical judgment. But what we are saying to our clinicians and both the population is that it shouldn't be wedded to the belief that you need to be seen every 6 months. But definitely, in short, there will be some clinical evidence to say that this is we should go down this route. But having a recognition of the high risk of cancer patients, for example.
Right. Okay. Still, I'd just like to follow that one up in a little bit more detail and whether I should do that through the Cancer Alliance. I'm just still not quite sure whether whether the clinical risk is related to cancers or the state of your teeth, to be quite honest with you.
Yeah, I mean, I can take that away and put it to our clinical advisor team, and then they can give you a much more scientific answer, if that helps, Simon.
Okay, Joe, I don't know whether Chris Byrne is our co-opted member, who's also chair of Swallows for head and neck cancers. Terry, I don't know. Chris is nodding. I don't know whether Chris wants to make a comment.
Yes, Joe? Yeah. Fascinating discussion. The way that I look at this is basically if a patient has got a mouth ulcer that is looking atypical, the advice is they go to their dentist to have the dentist actually check it out because GPs don't have expertise in this area. And if you're in a disadvantaged area, you don't have access to a dentist. Therefore, there's a higher risk of those patients progressing to more unhappy state in their, if they've actually got cancer. So there's a health risk there as well. Have you got any comments on that, please?
What I'm saying is that I'm limited in what I can say because I need my clinical advisors to comment on that. But what I would confidently say, Chris and Simon, is that we have been trying to promote particularly the diagnosis of cancer in dentistry. And one of the other things we've been looking as well is safeguarding of women and children, because sometimes these patients don't go to their GP, for example. They come because they've got a broken tooth, they go to their dentist. And we've been doing a lot of work to make sure that dentists are much more aware that they need to refer a patient where exactly as you've described, if they've got an abscess which is looking from a layman's term dodgy, they need to make sure that they refer them as quickly as possible. And equally from a safeguarding position as well, to make sure that if they can link up with other professionals to make sure that those patients who may be at risk are dealt with much more quickly. It's part of the wide agenda around every
Contact count.
every contact counts. Thank you, Simon. Yes,
Yep.
that's what I was trying to say.
So Terry, do you know, I mean, this is, again, you may have to take it back. Actually, if you would take it back to your clinical team, that might be
Yeah.
useful as well.
Yeah.
Because I was just thinking, if you ring up with tooth pain, NHS 111, they can make you an urgent appointment. But if you ring up with an atypical ulcer or an ulcer that just won't respond to, you know, whatever you daub on it and, you know, from the pharmacist, would they also pick that up and send you for an emergency appointment to the dentist? Because if that happened, then you could see that actually that would be a safety net, wouldn't it?
Yes. Now, I think this is about the pathway that NHS 11 follows. So yeah, you're right. I don't want to speculate on that one, Joy, if I may.
Yeah.
I need to take, I do apologize, but I think some of these things, we probably need to look at them much more and ask the experts to say, how do you deal with that? Because if you ring in, I don't know what follows. I know you get a clinical person to ask what you are presenting with and your symptoms, and they will tell you where you need to go.
Brilliant. If you could get back to us, that would be actually really helpful, Terry. Thank you.
Yeah.
Thanks, Terry. Thank you very much.
Thank you.
Alan.
Yes, thanks. Really informative. Thank you, Terry. I'm going to flag up another part of the population which for which there are some special considerations around dentistry, and that's people with learning disabilities and people who with neurodiversity. And we have had some specialist services in the past, certainly for learning disability. Is there, are they being kept in mind going forward as things are developed?
For Worcestershire as a county, we have got a special service, which is our community dental services, really looks after our learning disability patients, and also any part of the population that have got special needs, mental health, anxiety, in terms of, because when children who can't, who may have challenges in going to a dentist. So our community dental services is the main service that provide all of the, because they offer general anesthetic, anesthesia for those particular groups. So that's the service that is geared for that, Alan.
Thank you. Thanks.
Yeah.
My microphone on. Is it easy to get a referral into that? I mean, presumably there's a pathway to get a referral in to that.
Yes, they can phone in directly. I don't have the details with me. They can phone in directly. I think what we've done now, there is a line now, a direct telephone where they can phone in and they can be triaged, and the team are very much aware of what they need to do. But the community dental services are our main provider for special services. And special services is quite, in its term, also looks at various patients who would have extra needs that cannot be looked after by a high street dentist.
Okay, thanks, Terry. Bernie.
Hi, yeah, sorry, just to pick up on that, because I was going to put my hand up and ask about the LD community as well. So it's not really clear on the website about how you actually get a referral in if you're LD or anxiety or autistic, because it gives you the phone numbers for individual clinics, but it is a referral in service. So I think a bit of comms around that, because I know that obviously there's the paediatric side of things there too, but actually for those adults who struggle with the actually making appointments and going through that process themselves. I think we need a little bit of a clearer pathway on how you do that. And I was wondering actually during the presentation whether or not that data was inclusive of that community, that particular service or not, because I know it's a specialised service, and whether that data was just talking widely around the more universal access. So Terry, I don't know whether you can answer that, whether or not there's something there in terms of pathway and access for autistic people in LD, and also whether or not that information was inclusive of those specialist services.
Yes, so the data would, because in dental provision we've got one streamlined source of data. So anything that you do in dentistry is reported in the dental system, which then reports nationally, so that the cohort of patients you're talking about will also be included in the data set. And the other thing to say, some of the patient group, particularly they come through GPs. GP can refer patients with learning disability, mental health, or whatever special, for lack of a better word, special cases that may present. They can refer into the CDS to say, can you see this patient?
Thanks, Terry.
I think
Yeah,
Dave has
thank
got
you.
his hand
Yeah,
up.
yeah, I'm going to say
Sorry.
David.
Okay. First of all, Terry, I'd like to congratulate you on recognising that Evesham exists. I live in Evesham, and our situation with dentists is absolutely dire, as well you know.
Yeah.
Tonight we have a meeting of the Primary Care Network group, and I wonder if I can give them any good news about the future of dentistry in Evesham. And secondly, I wonder if you could give me an example of what a UDA is. What amount of treatment does £23 get for you?
So unit of dental activity. So if, for example, if you go for an agent, if you have got a, if you go for an assessment to a dental practice, you that will attract one UDA, one unit of dental activity, which is £23 for them looking at you and assessing and seeing what level of treatment you need. When it goes up, it steps into, so it's band 1 treatment that's classified as urgent. Then band 2 treatment is your extraction, and that's 3 UDAs. So that's about £69. So, but this is majority of our, I suppose this is contractual activity, so I can't share too much information about it. Although majority of our contracts in Worcester, they are around £27.84. That's our average. That's one of the things, because these prices were negotiated in 2006 when we had PCTs. So if you're a good negotiator, or you may end up with a higher price, and some people have got lower price. So it's not a unitary figure across the country. So that's one of the things that if you speak to our local LDC's dental committee, they got a bit of a grumble, because your neighboring dentist could be on £30 per UDA, and the other one having £21 per UDA or something like that. And it causes a bit of animosity across the board.
Last week, I had a broken tooth mended at as a private patient, and it cost me £484 to have it fixed. So I was just wondering how many UDAs I'd get for 480 quid. It took them just an hour to do it. That made a good job. Sure, I've got no complaints about the work that they did, but I think there's obviously a great incentive there to be a private patient rather than an NHS, private dentist rather than an NHS dentist.
Yeah, absolutely. On an NHS, that value, you'll be looking at the most complex oral health care they can give you, which is almost like what we call root canal treatment, which is much more complex for that particular part, and that's even more expensive on an NHS. So you can see the incentive that is drawing people to go into private.
Absolutely.
What I would say in specific to Evesham, what we are doing at the moment, I'm sure it's okay for me to share this information. We know when we lost the practice in Ifsham, we went to the local dental practices to say, listen, we have lost this activity. Would you be interested to take it on? But none of, we went across a 10-mile radius, which touched on Pesho as well, to say, would you be interested to increase your, and no one came forward because they said, Terry would like to do more, but we struggle to recruit in Ifsham. We can't get workforce to come. So what we are doing at the moment, we are planning to go even wider across Worcestershire to say, would you be willing in an interim position to deliver services in Ifsham on our behalf as a branch site, whilst we go through a procurement process, which will put us in a permanent footing. So that will be, procuring a new dental service in Ifsham, but that takes the procurement process. For some of you who've been involved in it, it takes about 9 months to land. So that's a long time without having dental access. So we want to do something interim, which is getting somebody to come in and even opening a clinic at the CDS site in Ifsham for whatever days of the week and seeing patients for a 9 months period whilst we are going through a procurement process. And then once we reach that, we can get another NHS service in the, hopefully, in the locality. So Ifsham, yes, it's one of my places which causes me sleepless nights because we're trying to sort it, but there are no quick, easy fixes, unfortunately.
Yeah, I did a survey of all the dentists in Evesham a couple of months back, and every one of them was had closed registration, if you like. They weren't accepting any more NHS patients at all. And in fact, the nearest NHS, the dentist that had is still willing to accept NHS patients was at Tewkesbury. So for older people like me, I'm getting on a bit now, it becomes more and more difficult to get treatment locally, and we just can't see an end to it at all. It's become absolutely absurd, the way that older people are finding services are getting restricted because of distance.
Actually, Dave, that's same for autistic people, and we're in Evesham as well. And there's no way that we would travel to Tewkesbury for a dental appointment for my children. With that survey that you ran, was that including children's services? Because I know that if some places were saying that they'll sign up a child if your parent is a private patient. I'm not sure whether that was something you came up.
There were dentists in Evesham that were accepting children as NHS patients. I'm not sure, Terry, why that is. Is there some extra incentive to have a child as a patient? But
yes, there is, and it's a common practice for some of our dental practice who don't know, who kind of want to navigate the system. But it's frowned upon because and all of our NHS contracts they're exceptionals, but they're very rare exceptionals. We commission services to service adults and children. This is a contract to service children only. So where that is put out, you need to challenge it because that's not correct. Because that's NHS will be tied up in legal notes for discriminatory practices. So anyway, the reason why, coming back to your question, the reason why they do that, because children are exempt in their treatment, so they can be seen on NHS, and then that gives them the ability to get, in a roundabout way, force parents to sign up as a private patient, but children being seen. So if you're a private paying patient, you might think that you're being done a favor by signing up as a private, but your children will be seen free, but that's not right. If you are an NHS patient, you still get that privilege anyway.
Right, thank you.
Yeah.
Do you want to know about practices that if we become aware of them that are doing that, Terry?
Yes, I think that's one of the things. So we hear anecdotal evidence about it, and in fact, we would want to know about it, particularly where you're told, we won't accept you unless if you sign up as a private patient, or we won't accept you unless if you sign up your children as NHS, something like that. We need to know about those cases. because
I
that's
think
not.
it's a bit more. It's more subtle than that. They just
Yes.
say we're not accepting NHS adult patients, so that they're avoiding discrimination because they're not discriminating. They're just saying we can't take on any more adults.
It's discrimination in itself, though, isn't it? Surely against poverty, you know, excluding the most vulnerable in society, including elderly, disabled, those on low incomes. It just absolutely horrifies me at the kind of level of vulnerability that we're just sort of letting get cycle of just out of control.
Yeah.
Okay, Simon, thank you. You've got a question.
Yeah, I have. Terry, you talk about re-procuring the service, but and you talk about the value of a UDA being linked to something to 2006, being fixed in 2006. But when you go out to re-procure, can you offer a higher value? Because without the higher value, I can't quite see how you're likely to have any more interest in providing the service.
So the 23 has recently been defined by nationally to say we don't see you sustaining your business at any value less than 23. So we have looked from a Midland point of view to say, do we have any contracts lower than that? And any of those we have identified, we've brought them up. I think we had one practice in Worcester. I'm not sure where it was, but it was only 50 pence lower than the national value. Now, to go back to your point, if we're going to commission a new service, we'll be commissioning it at an average price, and the average price in the current market for Worcester is 27.84.
Right.
Okay.
So there will be a better price for a new service.
If you are commissioning a new service, that would be that we go for it. It will be better. It's far higher than 23. I will just put it. Just to give an explanation why that is the case, we think that actually if you commission at 23 when everyone else surrounding you is much higher, then it doesn't attract anyone coming onto the market. And even if they come to service, they'll soon say, you know what, I've had enough, I'm going because this is too low. So we also recognize the business element of it, but we have got an obligation to the taxpayer to make sure that we're spending their money in a prudent and wise way, and we are guaranteeing a service that's sustainable and can give quality to patients, because we don't want someone who comes in cheap and then deliver a very poor service to the patient, which is just not acceptable. So we think that if we go at an average, it's not the best, wish we had a lot of money, but this is public service. We can only give what we've got because we've got restricted funding.
Okay, thanks, Terry. Chris, I think we'll make this a final question if that's okay.
Okay, thank you. I'll be brief. So is it possible to flex the budget, the actual revenue that you've got available to areas of higher deprivation so that they actually do not suffer the worst as a result of not having access to a dentist on the NHS?
I'll try to be brief as well, Chris, in the conscious of time. No, we have got a set budget in dentistry, which is so for example, if we give an example of if somebody hands back their contract, it will be handed back at the same value that we pay on a yearly basis. So we use that value to recommission service. Now, to get to the point of about how to reach or complex cases, because some practice may not want to deal with those patients, we are starting to recognize that and to do things much more innovative. So we have what we call flexible commissioning. We can agree with a new service to say, rather than delivering 20,000, for example, UDAs, we'll say deliver 15,000 UDAs, but the rest of the 5,000, we want you to do sessions for patients with complex cases. So we pay you on a sessional basis. So rather than worrying about, I need to count the bins, you just see patients and treat them on a sessional basis. And that seems to work really well.
Okay, thank you.
Yeah.
I think we probably need to discuss this further, but probably not
here.
Yeah.
I mean, that sounds like a really good way forward to do the sessional stuff, so that I suppose you're actually incentivizing dentists in a different way, aren't you?
Yes, yes.
Yeah. Right. Thank you very much, Terry. That was really interesting and very helpful. And please, I'm sure we're going to invite you to come to another public board meeting, because it's a very an area that everyone's really interested in at the moment in Worcestershire. But thank you very much for joining us, and thank you for your presentation.
No, thank you for having me and inviting me. And just to say, you know, reassured, we're working really hard. We're trying to improve the position we are in. It's not ideal, but we're working hard to try and sort it out.
Thank you very much.
Yeah, thank you.
Moving on. So the next item on the agenda is empowering carers on hospital discharge and the Worcestershire Acute NHS Trust's inpatient discharge policy. Jane, are you there, and can you talk?